Hello, my name is Ravi Vij. I'm from My Cancer Haven. And today I have with me Dr. Nathan Singh, who's one of the very upcoming basic scientists in the area of CAR T cell therapy. He's a clinician as well and trained at the University of Pennsylvania, where CAR T cell story started. We're really happy to have him. Welcome, Nathan.
Thanks, Ravi. Happy to be here.
So what we're going to talk about a little bit is, what is the state of the art on CAR T cells today? And because you're at the forefront of biology and trying to make these better for the future, where do you think this field is headed? What can patients expect in the future with CAR T cells? So first of all, where are we with CAR T cells? Where do you use them today?
Yeah, it's a good place to start. So CAR T cell therapy has been around as an idea for a long time now. The first patients were really treated in the late 1990s with therapies like this, but it took a long time for them to really progress to the point where they could really cause remission in patients with either leukemia or lymphoma, and now myeloma also. The first CAR T cell therapy was approved by the FDA in 2017. And that was initially for patients with really aggressive B-cell lymphomas. But since then, we've had a total of 6 therapies approved by the FDA across that spectrum of B-cell and plasma cell diseases like lymphoma, acute leukemia, and multiple myeloma.
So I guess in these disease states, the utilization of this is still being explored. And from what I understand is that initially started out in very refractory patients where no options existed, but slowly in these disease states, these are moving into less heavily treated patients to have even better results.
Yeah, that's true. So the first approvals were really for patients who had failed, essentially everything that was out there, many lines of therapy for lymphoma, certainly also true for leukemia. But the more recent studies have looked at moving this therapy to earlier in a patient's disease course. And there are a lot of reasons that you might want to do that. One of which is that the less chemotherapy a patient gets in general, the better. We've also seen that the less chemotherapy a patient gets who's eventually going to get CAR T cells, the T cells that are used to make this product are a lot healthier in a patient who's gotten less chemo as well. And so if we can find a way to induce a remission that spares someone chemotherapy, that's certainly going to be better. And for lymphoma specifically, we've seen some studies that show that these therapies can have benefit earlier in the treatment course. And I think for all diseases, these are going to move in that direction.
So what is a CAR T cell for the uninitiated?
Yeah, great question. So T cells in general, when we think about what a T cell is, T cells are a really strong component of the normal immune system. Their job is to, when you get an infection, go around, find all of the cells that have been infected, the normal cells in your body that have been infected with that virus or bacteria, and destroy them. And that way eliminate the infection that's going on and control the infection so it doesn't get out of control. This system has evolved to be extremely precise and exquisite in humans. And some very smart people a long time ago said, maybe we can use the specificity and potency of this T cell, of these circulating T cells, to retarget them instead of towards infections, towards cancer. And so the way that they do that is essentially they give it a new flashlight, and that's what the CAR is. A CAR is a protein that on the outside basically searches around for any cancerous cell, or a protein that's expressed by any cancerous cell. And once it finds that cell that expresses this protein, it will turn the T cell on and basically tell the T cell, this thing is an infection, we should eliminate it the way you would an infection. So by the use of this protein that combines a lot of different functionalities, you can essentially redirect this normal response that is designed to control infections, but to control cancer. I'll stop there.
So how do you go about the process of getting these T cells ready?
So currently, there are, for a long time, there were many different ways that we could engineer or re-educate these T cells to target cancer. But the majority of the products that are made now are all really made the same way. And that process starts with identifying a patient who's going to be a good candidate for this therapy, and then hooking them up to two IVs, basically, one that pulls blood out, one that puts blood back in. And in between that process, the blood that comes out, we remove the white blood cell component, the immune cells that are within the blood, and put basically everything else back in so that we're not really bleeding these people dry. We take those white blood cells, pull out from that white blood cell compartment the T cells, and that's where the engineering part of this starts. So those T cells will go into a laboratory where they're turned on and activated using a variety of different T cell activating reagents. Sometimes these are little magnetic iron beads. But regardless of what the process is, these T cells get turned on and then engineered using gene therapy. So gene therapy is a process in which we take a gene that's not normally expressed by a cell and deliver it into that cell so that it now can express that gene. And that gene that we're going to deliver in this case is the gene that codes for this CAR protein, this CAR receptor. Delivering that gene into the T cells, we grow them up in these in the lab so that we go from a small product of T cells into a much larger one that's more likely to have an effective response in treating a patient who's got cancer. Grow up those T cells, clean them up, make sure they look like they're supposed to through a variety of quality control metrics, and then reinfuse these cells back into the patient.
So as far as the product goes, when it arrives, before that, obviously it's gone through a number of steps. And what is it that constitutes a product that is up to the mark and safe? What are the kind of things that you look at to say this product is well manufactured?
Yeah, so early in the early days of this therapy, we were still figuring out a lot of what were the most important parts that we need to make sure have been checked and assessed for. So we've come down to a few important ones. Like with any transfusion product, we want to make sure that it's free of any bacteria or anything that could be infectious to the patient or cause harm by delivering an infection, particularly to a patient who's going to receive CAR therapy who's already got an immune system that maybe isn't working the way someone who hasn't received chemo would be. In addition to making sure it's clean like we would any other blood transfusion, we also, for almost all products, make sure that that expansion process, that process of growing these T cells in culture flasks, resulted in the development and the production of a sufficient number of cells. One of the benefits of CAR T cells or cell therapies in general is that once we infuse these cells, they can divide and expand in the patient also. So unlike classic drugs where you give a patient a dose and that's the most they're ever going to see, these therapies, we call them living drugs. They can go into the patient and expand once they're in there. So what you put in is not necessarily the dose that a patient's going to see over the course of the therapeutic response. But we've still found that we need to hit sort of a minimum threshold number of cells to make sure that those cells are going to have a positive reaction once they go in. Lastly, we really make sure that these cells, the engineering process of when we did that gene therapy reaction, giving these cells a gene, that resulted in expression of this receptor on the surface, and that enough cells within that product have been successfully engineered so that when we put it in, that flashlight exists on enough cells so they can go find these cancer cells.
And before you give the cells to the patient, I understand they get some chemotherapy.
That's right. So before, a few days before we'll give these cells to anyone, they'll get, I wouldn't call it a little bit, but it's not a large dose of chemotherapy, but enough that we can get rid of a little bit of any residual cancer that might be around, as well as sort of make space within the patient's body to receive these cells and be ready to let them expand, proliferate, and go do what they need to do within the body.
And the actual process of the infusion of the product, what does that entail?
Yeah, we always tell patients that while it's a really big, important moment in their lives and during their sort of journey with cancer, it's pretty anticlimactic. The actual moment of infusion is like getting a blood transfusion. The bags are usually pretty small, and the whole process usually takes less than 20 minutes. We hook them up, give them some pre-medications beforehand, like Benadryl and maybe some steroids to make sure that they're not going to have an acute reaction. but then just a cell infusion, just like you would a red blood cell transfusion, and then it's over before you know it started.
So obviously, most of these are being done in the hospital setting, though I know certain centers are now using certain products in the outpatient setting. What is it that requires scrutiny, and what is it that you're looking for when the patient's hospitalized, or if it's being done outpatient?
So that's a great question. So the reason that at a lot of centers, and most centers now, we still keep patients in the hospital for some amount of time after they receive these cells is because of the side effects that can happen after the infusion. So the day of infusion is almost always very uneventful, but then in the following days, we can see the effects of what's happening when these T cells do what they're supposed to do, which is go in, find their targets, become activated, kill the targets, and divide and expand within the body. And what we most often see, the side effect that's most common and for a long time was caused a lot of problems, including some deaths, was this syndrome called cytokine release syndrome. CRS is the term that gets thrown around for it most often. And what this is a hyperinflammation, a supreme inflammation of all of the immune cells in the body that results from the hyperactivation of these T cells going in and finding their targets. So in some ways, this is something that is, while it can be problematic, it sort of is a good thing. It reflects that the T cells are going in and doing their job and becoming activated and angry in the way that we want them to become angry. It's a complicated, the biology of cytokine release syndrome is very complicated and not fully understood, really. But we know that it relies on these small proteins that get made by both T cells and other immune cells called cytokines that are essentially little communicating proteins that tell the immune system, hey, something bad's going on. We all got to turn on and do our jobs. And the side effects of that are, A, that you get a lot of inflammation, which can cause things like fever, headache, rashes, sometimes a little bit of low blood pressure. But if there's too much of these cytokines and too much of this hyperinflammation, it can also cause organ damage, which is why we keep patients in the hospital to make sure that we can intervene on this if it does occur.
So just a sentence or two, when you intervene, what do you do?
Yeah, so largely cytokine release syndrome is a very manageable process now, a very manageable problem. In the early days, really no one knew what to do, but sort of by accident, we discovered that if we block the activity of one specific cytokine, IL-6 is the name of it, if we block its activity using a drug that has been used for decades to treat other inflammatory syndromes, basically we shut cytokine release syndrome down right at the start. Patients, once they receive this IL-6 blocking therapy, it's called tocilizumab, very often patients will, the symptoms of cytokine release syndrome will resolve sometimes within just an hour or two. And so it's really just, it's a stop valve for this syndrome that works incredibly effectively.
And if it doesn't work, what do you do?
So we've got now that we've learned a little bit more about the biology of this disease, we've got a few other tools in the toolbox here. We can always redose the tocilizumab, and sometimes, actually pretty commonly, we'll need to give a second dose because even though we shut that IL-6 off for a little while with the first dose, because those T cells are still very active, it can build back up again, and so we can treat it again with another dose of this drug. We've also got a couple different agents that can block IL-6 in different ways. Similar types of products that block cytokine responses, but that basically do the same thing. And sometimes we'll also use steroids to just sort of broadly shut the immune system down.
And I understand another thing that can happen is some kind of episode of confusion, altered sensorium. What can you tell us about this really tongue twister of a word, immune effector cell-associated neurotoxicity syndrome?
Yes, ICANS is another, it seems to be a side effect that's very specific to CAR T cells. It's a very unusual syndrome in which patients will develop confusion, but a really specific type of confusion. And almost always this starts with a difficulty in word finding or a difficulty in being able to write words. And that's usually the first sign that something's going on here. This can also, just like CRS can progress from initially mild symptoms to some more severe symptoms, this can also progress to more global confusion and inability to perform normal functions. The biology of ICANS is much more poorly understood, and we really don't have a nice specific targeted therapy for this yet, but there's a lot of research being done on really what's causing this so we can find a more targeted therapy.
So how does this, go in terms of a resolution? Is it something that usually gets better within a few hours, or can be more protracted?
Yeah, so this usually starts a little bit later than when CRS would normally start, and it usually lasts for a little bit longer than CRS would normally last. Oftentimes this resolves on its own, even without intervention. We know that from the early studies when we didn't really know what to do with it, and we just had the option to observe. But now we've got some interventions that we perform. We usually give patients pretty high dose steroids to shut down any inflammation that might be causing this syndrome, and also give them medications to prevent seizures. Seizures can be an unusual but sometimes seen side effect that can occur in more advanced phases of ICANS.
And then obviously there are some other side effects we know, with low blood counts and risk for infections. But again, the CAR T cells, are they curative for the cancers that they are approved for?
Yeah, there's been a lot of hype and attention about CAR T cells over the last 5 to 10 years. I think they represent a really important step forward in how we can more intelligently treat cancers. But the reality of the data today are that they are curative for some, but for most patients, these will not be a curative therapy. In leukemia, durable outcomes are a little bit better. But for lymphoma and myeloma, we still need to get these to beyond a sort of proof of principle to a state where they can really cure most, if not all of the patients.
So I understand lymphoma is obviously not one disease, but certain lymphomas like large cell lymphoma potentially can be cured, whereas the other ones like the mantle cell lymphoma and follicular lymphoma, we just don't have long enough follow-up. And even myeloma, we don't know, I guess.
Yeah, I think that's right. The data for myeloma particularly are just still so new that we're still waiting to see where things go.
So why do they stop working then?
Yes, this is the $10 million question right now, is why do these T cells either work in some patients and not work in others, or work in the beginning and then stop working, which is a pattern that we see a lot of the time, unfortunately. And so there are a few different reasons that have been identified so far. One that is particularly interesting, I think, and we've seen a lot more evidence of in leukemia, is that that flashlight that the T cells are given, the CAR itself, sometimes the tumor cells will go dark and stop expressing the protein that flashlight is looking for. And so once they do that, those tumor cells have now evolved essentially a way to escape being seen by the CAR T cells. And so that's often referred to as loss of target or antigen escape, where the tumors just have gotten a little bit smarter than the T cells. Other ways that this can happen outside of that tumor-driven escape is that the T cells, for a variety of reasons, just become too tired. They get exhausted is the term that's used for it. The biology of why that happens is not completely understood. It's what I study in my lab, is why do T cells get tired. But we know that when patients have a lot of cancer, those T cells can only do so much work before they essentially just give up. And we're trying to figure out ways to enhance how long those T cells can survive and do their work. But we're seeing that this is probably a cause of failure in more patients than we'd like to see it. A side effect of that exhaustion, of that inability to keep killing, is that they don't stick around. They don't persist. And so once those T cells get tired, they often will die. And instead of living for the life of the patient in the way that we'd like them to, they tend to disappear. And we know that those exhaustion and lack of persistence are usually signs that the disease is going to recur.
So how long do these persist for?
That's a good question and a very variable answer. So in some patients, particularly we see this in children who are treated with CAR T cells, we can see that these T cells will stick around for years. And so the longest, the patient, one of the first patients who was treated, not the first, but one of the first, is a young girl who we now can see that these cells have been around for 10 years and they're still detectable. More often what we see when we look in the blood is that these cells will stick around in patients who are being treated for lymphoma for a couple months, and then we tend to see them go away. That doesn't always mean that the disease is going to progress, but we think that those T cells are probably just hiding in places that are not the blood, and they're doing their job in a place where they're supposed to be active and not circulating.
So you say that your lab is obviously doing a lot of work in this area on T cell exhaustion and trying to improve the results of the T cells. So what do we know about trying to make these more effective?
Yes, there's a lot of work, as you can imagine, looking into how do we make these cells do what we know they can do, but do it a little bit better and do it more often. So one strategy that's been very intriguing is aimed at getting around that antigen escape, that loss of target. So if you can, say for example, engineer a T cell with two different flashlights targeting two different molecules that are expressed by cancer. If the cancer cell evolves to lose one of them, it can still be susceptible to CAR T cell activity because it expresses the other. Losing two by the cancer cell is much harder than just losing one. And so these are, we can do this in several different ways, actually. Combining two different CAR T cell products, one that targets one target and one that targets another, or creating a cell that actually has both flashlights on its surface. And that's having a single cell with two different CARs. There's also been a lot of really exciting work looking at how we can combine CAR T cells with other small molecules or therapies that we use in other contexts for cancer or other diseases that might boost CAR T cell function or sensitize cancer cells to be killed by CAR T cells. So that's a pretty active area of investigation also.
So obviously all the CAR T cells that we have today are, as you described earlier, produced using the patient's own T cells. You have to undergo this process of pheresis to collect them, and then the expansion and the return to the patient. But I understand there is a lot of research going on to try to cut the process short by not having to wait that long to get the product back for each patient, but try to get something that is produced on an industrial scale, like a drug. So what can you tell us about these attempts to get CAR T cells sort of off the shelf?
Yeah, this would be a dramatic change in how we think about this therapy. So there are a lot of reasons that in what we call an allogeneic or donor-derived product would be beneficial. As you said, it would significantly cut the wait time down for patients, particularly for diseases that are really aggressive, that move really quickly. Oftentimes, patients don't have the time to wait to get an apheresis, sending that apheresis product off to the manufacturer, having the manufacturer make the drug, quality check the drug, and then redeliver it back to the patient. That can take several weeks, if not longer. And so cutting that time down is really important. Also, the majority of these allogeneic therapies would be derived from a patient, or a person, I should say, who has never received chemotherapy. And so there's a thought that the T cells that are being used to make the product would be much healthier to begin with. And so there's a lot of efforts, and a lot of companies have been pursuing this heavily for the last 5 years to design strategies. Now, obviously, there are some clear benefits here, but the barriers to making this work are also very high. Similar to a bone marrow transplantation, there's a lot of complexity that needs to be addressed when thinking about giving a patient an immune system or an immune cell from another person who's going to potentially, those T cells are going to recognize the patient as foreign, and you can stimulate things, or potentially stimulate things like graft versus host disease, or the reverse, which would be the patient rejecting that allogeneic CAR T cell itself. And so a lot of technologies that are exploring this are using advanced gene editing like CRISPR to sort of mitigate those off-target effects that we might see with a current donor-derived product.
I know the field is still in its infancy, but can you tell us as to what we've learned in terms of the pros and cons of this approach so far?
Yes, I think we've learned that this is going to be much harder than we thought it was going to be. I can imagine that if you asked someone 10 years ago, when will we have an allogeneic product, certainly we would have thought it would have been by now. And I think a lot of those barriers result from the fact that the immune system is a lot more complicated than we even understand. And so finding what all we need to essentially engineer in this donor-derived T cell, outside of just putting the CAR in, what we need to engineer to make sure that that T cell is well received by the patient, can live for a long time in the patient, and doesn't cause toxicity to that patient, have been big barriers. But I think we're sort of in the chase, and I think right now the most successful studies so far have been really promising in the last year, that I think we're within sight of this becoming a reality.
And obviously, we've talked about T cells, which are only one of several kinds of immune cells in the body, and whether they be autologous, as we discussed initially, and what we just discussed on the last slide, allogeneic, which is donor-derived T cells, they're still T cells. But what about using other immune cells to attack cancer?
Yeah, there's a lot of work out there right now looking at what the other types of, as you said, other types of white blood cells, other immune cells, as sort of mitigating the same effects as a T cell might. And whether these therapies would be in replacement of or instead of CAR T cells, or maybe go along as complements to CAR T cells where you deliver multiple cell types to one person, I think we still don't know. You have a list there of a few different cell types, and there have been a few studies of all of them really looking at how they may work. The most promising so far really are NK cells, which are sort of a cousin of T cells, and sort of either using naturally occurring NK cells or engineered NK cells to target diseases. I think also has a lot of promise. So I think this slide really reflects that in the next 10 years or so, we're going to see a burst of new cell therapies in addition to T cells that maybe can allow us to do this much like we would chemotherapy 50 years ago, sort of pick and choose a few different functionalities and use them together to achieve a synergistic benefit.
Well, I really appreciate your taking the time out to educate us about the biology of the disease. I mean, CAR T cells essentially, and where we are going. Seems like we've just started this journey, and there's going to be a lot more coming, and better CAR T cells and better other immune cells. Is that fair to assume?
Yes, I think this is just the tip of the iceberg. I think we're going to see really almost like we've probably never seen before, an explosion of completely novel treatment modalities. And this is really just going to benefit people. The benefit, that we can see, the promise, I should say, that we can see with immune cell therapies is much more specific targeting, which means better, more durable responses with a lot less toxicity. So I really do think the future for cancer has been changed by the advent of this type of therapy, and the future is certainly going to be exciting and bright in the next 10 to 15 years.
And all due to the effort of people like yourself who've been toiling in the lab to make this a reality for patients. So, and obviously you're a clinician as well and look after the patient. So we need more people like yourself.
Well, it's been a long, slow effort, but it's nice to see progress when it happens.
Well, thank you very much. And I hope I can reach out to you one of these days for more updates as the field advances forward.
Anytime. Thanks, Ravi, for having me.